Welcome everybody to the Implementation Toolkit for Small and Sick Newborn Care webinar. Welcome. Please introduce yourself in the chat. Today's webinar will be focused on the OMWaNA trial that was based in Uganda, and it was published in the Lancet paper just yesterday in time for World KMC Day. Next slide, please. Welcome, everybody. My name is Dr. Mbozo Sipalo. I'm the Knowledge Management Co-Lead of the Newborn Toolkit, primarily focused on our English-speaking audience. We welcome you to our Newborn Toolkit community. This series aims to encourage collaborative learning for faster progress together for small and sick newborn care. Our 2024 webinar series is structured around the WHO UNICEF 10 core components of small and sick newborn care. Today's webinar is a very exciting one based on the OMWaNA trial that was in Uganda, and the Lancet paper was just published yesterday. It's on the theme, what is next for Kangaroo Mother Care before clinical stabilization, Uganda's OMWaNA trial and economic evaluation results in new Lancet paper. Welcome everyone once again. I'm delighted to update that in 2023, the Newborn Toolkit had more than 27,000 users from more than 170 countries. And it's very exciting that we're joining together to celebrate this latest paper. So we'll have two exciting events coming up. On the 4th of June, we have a webinar, Where is the Power? And on the 18th, we have one on humanitarian crisis for the most vulnerable newborns. Welcome. Please introduce yourself in the chat. Next slide, please. And now I'll hand over to Lauren Allison. Lauren.
Thank you. Alors, bonjour et bienvenue à la webinaire. Si tu veux écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton affiché en bas de l'écran. Et je veux aussi noter qu'il y a deux événements à venir. Le prochain webinaire est le 4 juin sur l'infrastructure, où se trouve le pouvoir. Et le webinaire après est sur le 18 juin et les crises humanitaires pour les nouveau-nés les plus vulnérables. Et cet webinaire sera en français, traduit à anglais. Hello, bienvenue. And I'll just pass it over to our hosts.
Welcome, everybody. So wonderful to see many of you here. And it's just my great honor and delight to share the hosting today with my fellow Ugandan, Dr. Peter Waiswa. Peter, I don't know if you can put your camera on. So Peter and I were recognizing that we've been working together for almost 20 years. And this trial that we're sharing with you today has been 5 years in the gestation. And we're so delighted today to be able to say that it has been published in Lancet last night. It's open access, so please do use this QR code to reach the paper. And we have really a big family of people to thank. But first of all, we may like to wipe COVID from our mind, but COVID was a very real challenge for all of us during this trial. And we want to thank each of the site teams, but especially thousands of families who were involved in this trial across all of Uganda, and that this was able to be delivered with more than 2,200 babies. And during that time period really reflects the resilience of Ugandans and all the teams involved. And this is the team at the start in 2019. The team was much larger by the end. And what does OMWaNA stand for? It stands for Operationalizing Kangaroo Mother Care, initiated before stabilization amongst low birth weight neonates in Africa. OMWaNA also means little child or baby in Uganda. And we want to reflect that human face. Kangaroo Mother Care isn't about just a biomedical intervention. It's also a big social behavioral shift in wards with a baby and a woman and the family at the center. Thanks so much to all the implementers. And Peter and I stand here together from the London School team and the Macquarie School of Public Health. But the real implementers that ran this were at the hospital teams in each site and linked to the MRC UVRI in Uganda, and you will see and meet many of them during this webinar. We also want to thank the funder and those technical committees that often are thankless that sit behind this. So we know that on the call today, many of the technical steering committee and data and safety monitoring board are here and have really provided critical reflections and insights throughout. And I'm now going to pass to my Ugandan brother to make some comments on the funding. So over to you, Peter.
Thank you so much, Joy. A nice meeting you once again. We would like to thank especially the funders for this trial. The funders have not been able to attend, but they sent a message, as you can read it in the chat. This is funded by the Joint Global Health Trials. And for us in the newborn space, we are so happy because usually they've not funded a lot of studies around newborn health or maternal newborn. So this is quite important, and that they have been able to send even a comment which emphasizes equitable partnerships. And this study was indeed equitable. As you can see, a lot of Ugandans on the team, but also collaborating with our colleagues from around the world. But also they found an important trial at an important time. As many of you know that newborn health is what is keeping most of the countries from reaching the SDGs and improving their human capital potential. So we are very grateful to the funders. Next slide. And this is going to be the agenda. As you can see it is in 3 parts. First of all, we'll hear about the trial, then we'll get the results, and then we'll get questions and answers. And I would like to encourage each of you, if you have a question, please put it in the chat, and we shall try to respond to all questions. Next slide. And most important, to introduce a colleague of mine whom actually recruited into this work and then came on the team and is led the trial. Dr. Victor Tumukunde is a PhD student at Lana School of Tropical Medicine, but also works for the MRC UVRI and the Lana School of Tropical Medicine. And we call him Dr. OMWaNA. OMWaNA means a baby from my language, but also from a language of many people in Uganda and other African countries. So, Dr. OMWaNA, over to you. Next slide.
Thank you, Peter and Joy. Good afternoon, everybody. You're welcome to this presentation, and I would like us first go through the Kangaroo Mother Care by definition. As we know that 15th of this month is the International Kangaroo Mother Care Day. And by definition, we look at 3 components: the skin position, breastfeeding and support, and also the, discharge and follow-up. So when we started the trial, the WHO guidelines 2015 emphasized the question about the cost, feasibility, and impact of KMC on neonates prior to clinical stability. And while we were running the trial, next slide, please, there was a groundbreaking trial by WHO, which was published in 2021. And this was followed by a change in the guidance for care of small babies. And these ones recommended that KMC should be practiced for all the babies who are 2.5 kgs and should be started immediately and for 8 to 24 hours a day. While this was happening, the OMWaNA trial was still going on in 5 hospitals in Uganda. And all these hospitals were situated in the central part of the country and eastern. And they were all level 2, they had all level 2 NICU grading facilities. And before we could implement, we had to refurbish in all the 5 hospitals. And you can see the before and the after photos. how it was and what we did. Particularly important were the bathrooms for women and also increased floor space for KMC beds. And also we had just marginal staff increase, but also looking at the floor space increase, we had out of the 5 hospitals, we had between 17 and 140% more space added for NICU space. One had just had a recent refurbishment, so nothing was done on the floor space, but we had to improve on oxygen pipings. So the refurbishment was really costly, and it was really a challenge for that delayed the start of the trial. And at the beginning of this trial, next slide, we published the trial protocol. The details will be sent in the chat if you want to get the details about the trial. And next slide. So we had 4 main objectives. One on mortality effect, economic evaluation, the causal pathway for the clinical effect, and also implementation barriers and facilitators. But for today's presentation, we shall focus on 1 and 2 mortality and economic evaluation. So now let me welcome my colleague, Dr. Charles Opondo, who was a trial statistician, to take us forward.
Good morning, good afternoon, everyone. My name is Charles Opondo. I'm Associate Professor of Medical Statistics at the London School. I was a trial statistician on OMWaNA. I'm going to be presenting the outcomes based on I'm going to be presenting the results based on the primary outcomes. And then I will introduce my colleague, Professor Carly Tan, who's going to talk about the secondary outcomes. So the OMWaNA trial screened over 15,000 neonates, and 15,000 is a really large number, and this was managed just due to the great effort put by the teams based at the hospitals in Uganda, doing all the screening and recruiting of participants. So out of the 15,000 neonates who were screened, we managed to recruit just over 2,000, and whom we randomly assigned to receive either the intervention, which was Kangaroo Mother Care, or control. And as you can see from the next slide, is that those numbers split beautifully evenly between the 2 arms. Now, after excluding a few participants who withdrew or were lost to follow-up for various reasons, we had just under 1,100 in one arm and just over 1,100 in the other arm, for whom we had the primary outcome, which was day 7 mortality. And after whittling them down even further due to further losses or withdrawals or deaths, we have just under 1,000 with day 28 outcomes. So mortality at day 7 was the primary outcome. When we planned this trial, we assumed it would be just over 20%. But if you think back to the improvements in the facilities, which Victor has described, you can then begin to understand how eventually we observe the low mortality rates of 7.5% in both arms. So we observed mortality of 7.5% in both arms, clearly no evidence of a difference in that outcome on day 7. By day 28, there were slightly fewer deaths in the intervention arm, 11.3% compared to the 12.8% in the control arm. But again, here, there's still no clear statistical evidence of a difference. But single trial does not change policy. So we also looked at other trials of KMC prior to stability, focusing on mortality at day 28, because this was the outcome that was common across all of these trials. And you can see that there was a pattern towards benefit in favor of KMC. In particular, the WHO 2021 trial did seem to show nearly a quarter relative reduction in the risk of mortality. However, in the largest of these trials, most of the neonates who were recruited at Indian sites, which are contextually rather different from the African sites. And so when we pooled the data focusing on African sites alone, this is the pattern we see. First, we see a range of relative reductions between 11 and 24% in day 28 mortality, quite consistent across sites. And when we pool them all, we see a 14% relative reduction in day 28 mortality, with quite convincing statistical evidence of a reduction. So that is a summary of the results according to the primary outcome. I'm now going to introduce my colleague, Professor Kali Tan, to talk about the secondary outcomes.
Thank you, Charles. I'm now going to share with you the findings relating to the secondary outcomes, in addition to analyses on Kangaroo Mother Care timing, duration, and dose response, where we saw a number of important associations. Firstly, the findings with respect to hypothermia, time to stabilisation, and death. There is a clear existing evidence base linking hypothermia to adverse neonatal outcomes amongst preterm infants, meaning we were anxious to look at this as a secondary outcome in the OMWaNA trial. In our trial, we saw that hypothermia in the first 24 hours was significantly reduced amongst those receiving Kangaroo Mother Care prior to stability. Time to stabilisation was slightly, if significantly, increased in the Kangaroo Mother Care arm, and there were no differences seen in the time to death. Next slide, please. With respect to weight gain, feeding, and related event outcomes, we saw significant improvements in daily weight gain amongst those receiving Kangaroo Mother Care prior to stability. Time to exclusive breast milk feeding was, however, increased in the Kangaroo Mother Care arm, although this was likely related to increases seen in duration of hospital admission time amongst those receiving standard care at the largest recruitment site. The largest recruitment site was a national referral hospital where, with immense pressure on cot capacity, and that frequently led to reduced duration of stay in the standard care arm. Next slide, please. As you can see here, at the top of the slide, the time to hospital discharge was increased, as I was saying, amongst those receiving Kangaroo Mother Care. But there was also a trend towards reduced rates of readmission, although not statistically significant. No improvements were seen in the maternal outcomes that were measured as part of the secondary outcomes of the trial, being women's well-being and maternal infant responsiveness at 28 days. So what did we see when we looked at duration of Kangaroo Mother Care and dose response? In the Kangaroo Mother Care arm, the median duration of Kangaroo Mother Care was 10 hours per day, with a median total Kangaroo Mother Care time of 60 hours. We found strong positive associations seen between duration of Kangaroo Mother Care prior to stability and both 7 and 28-day mortality, with an adjusted risk ratio of 0.17 and 0.19 respectively. Similarly, a significantly reduced risk of mortality was seen amongst those who received Kangaroo Mother Care within 24 hours of randomisation. Overall, this suggests that there may be a substantial survival advantage for those receiving earlier and longer durations of Kangaroo Mother Care. Next slide, please. So in summary, we've shown significant improvements in 28-day mortality across the African sites of 3 relatively similar Kangaroo Care Mother trials, with a pooled reduction in 28-day mortality of 14%. In OMWaNA, power was reduced due to rate reductions in pretrial mortality, likely related to improved infrastructure for care of small and sick newborns, including the creation of mother NICUs, as per Victor's presentation earlier. It's important to note that early neonatal mortality was not significantly reduced across any of the trials. However, in OMWaNA, earlier and longer durations of Kangaroo Mother Care were associated with improved survival. With respect to secondary outcomes, we saw improvements in hypothermia episodes in the first 24 hours and in weight gain for newborns in the Kangaroo Mother Care arm. However, there was a small but important increase in duration of admission, with a trend towards less readmissions. In summary, there is good evidence from across these 3 trials that kangaroo care prior to stability, early or immediate kangaroo mother care reduces 28-day mortality amongst small, vulnerable newborns, including in African facilities. But perhaps now the most pertinent question is, how do we best support implementation of kangaroo mother care prior to stability for women and their newborns? And importantly, what is the cost? And on that note, it's with a great pleasure for me to hand over to my colleague, Melissa, who is going to share with us the findings of the economic evaluation. Melissa is an Associate Professor of Paediatrics at UCSF, a clinical researcher at LSHTM, and was one of the OMWaNA trial co-PIs. Over to you, Melissa.
Thanks, Kelly. Next slide, please. So the economic evaluation for the trial aimed to compare the incremental costs and cost effectiveness of KMC before stabilization relative to standard care from a disaggregated societal perspective, which means both healthcare provider and household costs combined. We examined both financial costs, which reflect actual expenditures, and economic costs, which reflect the full value of resources used, including donated time and other factors. We collected data on resource use for each neonate regarding medicines and therapies administered, type of care received, meaning KMC, radiant heater, or incubator, duration of hospital admission, and individual level medical supplies used. We also collected data on the costs of hospital setup, staff time, electricity, water, and generic medical and non-medical supplies in order to estimate the unit cost of each night spent in the hospital per baby by type of care and by hospital. These unit costs were then applied to individual babies based on the duration of each type of care received. Costs were collected in the currency in which they were incurred, inflated to 2020 values, and then converted to US dollars on the basis of average exchange rates in 2020. Next slide, please. So in this table shows the incremental costs and cost differences across all of the sites. Within the paper, you can actually see the analysis by individual hospital. But across all 5 hospitals in the trial, the economic cost to society per neonate was similar between the intervention and control arms, with an adjusted mean difference of negative $7.2. There was weak evidence that provider economic costs were lower in the intervention arm compared to the control arm, with an adjusted mean difference of negative $9.4, but this was not statistically significant. And we found no overall differences in household financial or household opportunity cost between the 2 arms. Next slide, please. We used an incremental net monetary benefit framework to calculate the probability that choosing KMC over standard care would be cost effective. Applying the assumption that policymakers place no value on averting neonatal deaths, we found that the intervention would have a 97% probability from the provider perspective and an 84% probability from the societal perspective of being more cost effective than standard care. In the event that policymakers were willing to pay $400 to avoid a neonatal death, the probability of cost effectiveness would increase to 98 to 99% from the provider perspective and to 88 to 91% from the societal perspective. Next slide. And this figure shows the drivers of total provider economic costs between the intervention and control arms, and this is based on complete case analysis. Across all 5 hospitals, staff time comprised 63% of provider costs in the intervention arm and 64% of provider costs in the control arm. Staff time and electricity cost less in the intervention arm than in the control arm, and outweighed the slightly higher provider costs of hospital setup, water, drugs, therapies, supplies, and transport. Next slide, please. Duration of hospitalization was similar between arms at 4 of the 5 hospitals. And at those 4 hospitals, provider and economic costs were consistently higher in the control arm. However, at Hospital 4, which was overcrowded and it was the largest hospital, duration of stay was significantly shorter among babies in the control arm than it was among those in the intervention arm. And costs per neonate at Hospital 4 were therefore lower in the control arm for both provider and societal costs. Associations between duration of stay and household costs were unclear. Next slide, please. And just to summarize the overall results and implications, OMWaNA is the first study to evaluate the costs of KMC among neonates before clinical stabilization, and the first to assess the societal economic costs of KMC, importantly considering opportunity cost households. We found that KMC before stabilization was cost effective compared to standard care from the provider and societal perspectives. The intervention would be expected to be cost saving to both providers and society in settings where KMC before stabilization reduced the length of stay from 7.3 days to 6.1 days. Staff time comprised nearly 2/3 of provider economic costs in both arms. And finally, duration of hospitalization was a key driver of both provider and societal economic costs. Thank you.
Wonderful. Thank you for that concise and really thoughtful summary through both the trial results and the economic results. Now, we've got a few questions in the Q&A, some of which I think can probably be answered by people typing, but we really welcome other questions. So what we suggest to do is we've got a very powerful film that we'll move forward to, but we encourage people to put questions in the Q&A, and we will have time for Q&A. So going to move forward to this very moving story of Dr. Sheila Oyella. So Dr. Sheila is one of the site paediatricians from the 5 hospitals. And one day she's on the ward looking after babies, and the next day she had a 29-weeker herself. And this is her powerful story of what KMC meant to her and what was the reality of that in her life and her baby's life.
Thank you, Joy. I am a mother of 4. Unfortunately for me, all my other 3 babies were born at term. And unfortunately, on the other hand, my last baby was born as a preterm at 29 weeks. He weighed 1.39 kilos. Unfortunately, he was quite sick. He had difficulty in breathing. He was having feeding intolerance, and he had sepsis. And being a pediatrician, I didn't know it was such a huge task. Fortunately for me, KMC was started quite early while the baby was still unstable. We had tubes running all over, and one day I walked in with a relative and they were so scared to see all the tubes going around, but here I was and I had to do KMC with all those tubes. Now the challenges I faced at KMC, this baby was quite sick and quite floppy. Like you feel like the baby is slipping through your hands. You can't carry them. So you really had to gather them and put them on your chest, skin to skin. And I needed the medical team to help me. Fortunately, they were there. At that time, prematurity comes at a time when you are not prepared for anything. So I didn't have what I would adequately use to tie my baby in KMC. So I had baby sheets that I used. Yes, I improvised to tie the baby on KMC. Unfortunately, that is not, usually it gives you that feeling like your baby is not secure, your baby is slipping through. So there was no way I could stand up and walk around, even in that little space. I felt like my baby was falling through. So many times I had to confine myself on the bed, on my back, to make sure my baby was secure. The other major thing is the confinement within that KMC room. You are within a little space. I am going through this emotional trauma. So much went through my head that at some point I actually had no breast milk. I had to look for a breast milk donor to help me go through this phase because psychologically I was going through a lot. Personally, I felt like, yes, I needed the social support. I called Dr. Victor Tumukunde and I told him of my feelings like the sheets were not doing me good. And yet the trial had the KMC wraps. And yeah, Victor was there for me in time. He provided, he came with 2, and I can say that did wonders. We all became confident at that point. The father came in and he was there to help with KMC. That really relieved me. And because of that, our baby, now 4-year-old, is named Victor. He is Victor because of Victor, Dr. Victor Tumukunde, and because he went through the challenges of prematurity and he is victorious.
I love that, Sheila. And so you also shared with me that this way of doing KMC gave you confidence at home. Can you maybe share some of that story?
Personally, for me, in the beginning, it was quite hard, but by the time I was leaving home, I actually requested discharge. After some time in hospital, I felt I was confident enough to look after my baby at home in terms of feeding, in terms of providing warmth, and in terms of picking any danger early enough because the baby was with me throughout the day and you're really monitoring and you feel you're in charge. I think for me, that was the greatest thing that KMC did for me. But also, importantly, I think it made me a better pediatrician. When I came back, I could relate what this mother goes through, and I was there to provide the support. I actually organized my team better to say, no, what this mother needs is not why did you miss to feed the baby at this time, but how can we help her? I told them there are days that there was a day I was in hospital and I told the nurse, today I am not doing KMC through the night. Keep my baby in the incubator because I felt fatigued. So I think when I came back, I was a better person.
Oh, well, Sheila, we really salute you and appreciate what you've been through, both as a parent and now as a stronger pediatrician. So if you were to look in the eye, the people from the government of Uganda, other funders or leaders, what would you say needs to be done to take forward both what you have seen in the evidence, but also your own experience? What should be done differently now?
Many times, when we lose a mother to birth-related conditions, the world makes noise. But I don't know how many people make noise when we lose this preterm. So we still have a long way to go and we need so much. Moving forward, I think we need physical space in all the health facilities that actually handles deliveries. Luckily for me, I think I've had opportunity to move to many health facilities. And many times you'll find there's not even one kangaroo care bed for these mothers. And so you really know what will happen. So we need the physical space. This mother needs a kitchen where she can fix herself a cup of tea. We are not going to be waiting for porridge from home. I know in that, what I went through, sometimes you're in hospital, you had supper yesterday, then you're waiting for breakfast from home and it is 11 and you're wondering. So you wish you had a kitchen next by where you can fix yourself something. And then we need good washrooms where a mother can feel comfortable to go and change, to go and shower, to go and ease herself. It would be very nice to have this structure have an opening into probably a compound, a green compound, where you get the fresh air, you feel, you know nature refreshes. I was there in the room with 4 walls around you and you're wondering, by the end of the day, you're fatigued, you're irritable, you're everything. You can mutate to something else. So having that infrastructure that is really conducive would actually make KMC a practice that we can handle better.
Thank you, Sheila. That's just so powerful and beautiful and really appreciated.
Thank you, Joy. I am a
So I saw some hearts going up during that film, and you know, maybe we pause just to reflect on how powerful that story is as a parent and a pediatrician. But Peter, maybe would you like to make some comments and reflections on Dr. Sheila's story?
No, thank you so much, Sheila. And I know I've heard the story from you in person, and it is a tough one, but yet also important, because many times as doctors, we are not even being so personal and thinking about what are people going through. And I think this makes it very, very
Thank you,
powerful.
Joy.
I liked when you said good washrooms. And I wanted to do a project on photographing bathrooms in hospitals in Africa. This is a place even sometimes no medical specialist goes to, but also you said a green environment. So I think your experience brings a lot of power, one on the possibility that can happen if you do Kangaroo Mother Care, but also on the fact that everything helps. Actually, in the commentary that was done by my colleagues at the School of Public Health, they talk about mental health, that it must be part of this Kangaroo Mother Care. And I think, do you want to comment on that briefly, on the mental health aspect and why it's important? And then we can go into the panel.
Yeah, thank you, Peter. And I think we welcome comments and questions on that mental health part. You know, that the mother cannot just be an intervention for the baby. She's also a human being with rights herself. But I think there are quite a few questions that are being answered as we go through. So what I suggest maybe we do is to go into the panel, and then we come back to a longer time of answering questions, if that's okay. So please do keep posting your questions. I see lots of really rich questions from many people, including many of the African Neonatal Association leaders. So maybe if it's okay, we move forward into the discussion panel, and then we'll have time for questions after that.
Thank you, Joy.
We're really privileged to have a very rich discussion panel. Sorry, I'm just struggling with my, okay. And, you know, this study was done in Uganda. I'm also a Ugandan, nearly a Ugandan neonatal death, and it's our honor and privilege to welcome Dr. Richard Mugahi, who's the Acting Commissioner of Reproductive, Maternal and Newborn Health in the Ministry of Health, Government of Uganda. And Richard, we salute the ambition across Uganda and the government of Uganda for meeting sustainable development goals for maternal mortality and progress there, for neonatal mortality, and the recognition that, you know, probably the speed needs to double in the next 5 years. So I'd like to ask you from your side what the government of Uganda is planning. I know you have ambitious plans to take forward for newborn care, including KMC. So over to you, Dr. Mugahi.
Joy, I think Richard is struggling. It seems is on
Okay.
Is on a wrong link.
Oh,
If somebody could think, maybe send him the right one. But meanwhile, let me first ask Professor Gary, as Richard can come in to close it as a key policymaker in Uganda. But somebody should send him the right link. And Professor Gary, actually, you have been at the forefront. You used to work for the Gates Foundation and funded actually some of the first studies, SNL2 in Africa, with Joy coming back to Uganda. But now you're also a professor at Stanford University and co-chair of the WHO 2022 guidelines that recommended this intervention. I'm happy actually to have been part of that very committee. But Professor Gali, what are the implications from the OMWaNA trial for practical uptake of immediate KMC for unstable neonates? And do you find that your recommendations you made are actually implemented in this trial? Professor Guy.
Peter, thank you very much. And thank you, Joy. It's really a great privilege to be with you. This is really a day to celebrate. We've been talking about KMC for 25 years, and it's just amazing to see the amount of data and what's been accomplished within Uganda on taking forward immediate KMC. As Peter mentioned,
Thank you, Joy.
I was co-chair of the guideline development group at WHO that recommended immediate initiation of KMC for preterm low birth weight infants. At that time, we had about 3,500 preterm infants in studies, and in 4 different studies that we were able to look at. You've now added 2,200 infants and from level 2 nurseries. So this is really an amazing accomplishment, the addition to the literature, and particularly the level 2 evidence that was missing, and really where most preterm low birth weight infants around the world are cared for. So this is an extremely important addition. I wanted to make a couple observations from the data side that I think are really important here. One result that really caught my eye was the fact that while you saw a 12% decrease in 28-day mortality overall, that was a non-significant result, but it became significant when you looked at babies who were initiated to KMC in the first 24 hours, and if they had received 12 or more hours of KMC in a day on average. This is extremely important. The early initiation and the prolonged skin-to-skin contact, that is really life-saving. It was incredible that within 24 hours, 83% of babies were initiated to KMC. That this is a huge accomplishment at this level. And I do note in the IKMC trial reported in 2021, the mean was 1.3 hours. So that really set a tremendously challenging bar. That was in a NICU situation, so it really is a very different context. But I think it does help to highlight the really important issue of early and prolonged skin-to-skin contact, and what does it take to make this possible? I think that's really the important part here is how do we shift our systems and make the investments that's required to make that possible. Another observation that caught my eye is that the average time to discharge was 7 days, and whereas no mortality, significant mortality impact compared to the control was seen in the first 7 days in the early neonatal period, there was a divergence, and there was life-saving in the intervention arm after that 7-day period. So that really took place at home. And one thing that's kind of missing from the immediate KMC literature is discussing the importance of the post-discharge follow-up care and how to make that as seamless as possible, and how to integrate across care in the hospital with care out in communities. I also noted that the time to discharge of 7 days was about half that seen in the IKMC trial, where babies had stayed for 14 days on average. And so clearly we have a different context in level 2 nurseries in sub-Saharan Africa, in Uganda in particular here, that we really need to be thinking about. And again, what's going into our discharge, and how do we think about optimizing the impact of KMC both in hospitals and in the follow-up care out in communities. So very briefly, 4 important implications. One is that immediate prolonged KMC is life-saving, it's cost-effective, and it should be done in level 2 and 3 nurseries around the world. You have shown that very strongly to us through this trial. It's really important that it be initiated as early as possible, and that we focus on prolonged skin-to-skin care, skin-to-skin contact, and taking a look, and this really came out so strongly in the super inspiring film, what are the health system and infrastructure changes that are needed in order to make that possible, to support families and staff in providing that immediate, prolonged skin-to-skin contact. We need to improve our discharge follow-up. In the 2022 WHO recommendations for care of preterm infants, we for additional home visits for preterm infants, as well as family support. And I think those are elements that are really important to further emphasize as we think about how to improve our outcomes further through KMC. And then finally, I hope that you have the opportunity to look at long-term benefits. We have some evidence for the long-term impact on economic productivity, on the cognitive benefits, on behavioral benefits of KMC. I hope you have the opportunity to look at that among your cohort. So thank you very much for this opportunity to comment on this really important work. Congratulations.
Thank you, Gary. And just such a privilege to hear your wisdom. It's been, I was reflecting, we're old now, it's 25 years, I think. And I particularly want to underline the very important point you've made about short length of stay. So in these busy, crowded units, we're sending babies home at day 5, day 7. They're still very vulnerable. And then we don't have proper follow-up systems. This is really critical. It's critical in practice. It's critical in implementation research. How do we make that work? I know that WHO have a committee that's going to be looking at this, and I would really challenge all of us. We've got nearly 300 people on this line now. Each of us can find ways both to do better in facilities, but also this follow-up. Also want to challenge the funders, because it's the experience, I think, of nearly everybody involved in this work, that the funders often don't fund follow-up studies. This is really critical. So I'm going to move from Gary and these really thoughtful comments to Dr. Olafunke Balaji. So Olafunke is a very dynamic and wonderful neonatologist in Nigeria, and she's famous to many of us as a key lead within the African Neonatal Association, who are really prioritizing KMC. So Olafunke, I'd like to ask you, looking at these results and looking across Africa and your role in leadership in the African Neonatal Association, how do you see what needs to be done? What are the priorities in moving forward to change outcomes for newborns and include KMC, more of it for more babies and earlier? Thank you.
Thank you very much, Joy. And I'm glad we've had such an impactful afternoon, and we've really had wonderful conversations with the results that have come in from this study. So at the African Neonatal Association, we're saying we need to push for more of what has been proven to work, the evidence-based strategies. And now we've seen that, I mean, in the outcomes that we've looked at in this study, we've seen that KMC works. So we will say more of investment into human resources for health. You can imagine if we had 20 Dr. Victors on that trial, that would have made such a difference. I'm glad that the way Sheila shared the story and how Dr. Victor came through for her. So we need more investment in human resources for health. We need more investment in purpose-built newborn units. Dr. Sheila talked about that cramped space in which she had to do KMC. And we're saying we need to do more investment into this. The ANA is saying over and over that we need to look at the sum total of what is working to reduce neonatal mortality. We need to look at the sum total of what is working to reduce newborn morbidity, not just one single intervention. So if we talk even about KMC, we have to situate it into the totality of care for small and sick newborn. We have to learn to support in our facilities across the ANA. We need to support women. We need to support families. And even our data RAM of the ANA, that's the African Neonatal Network, we're beginning to see even from our data that we need to do everything together before we begin to see a difference in the landscape of newborn health in Africa. We need to do more of respiratory support. We need to do more of infection control. So rather than seeing each intervention as a magic bullet, so to say, we need to package it together as bundles of care, and before we begin to see the differences that we're hoping to see for newborns in Africa. I want to say specifically that I think that KMC can bring about that transformative shift for both clinicians, providers, and families and parents, and even the babies. It changes the entire landscape, but more we need to situate it in the context of the entire small and sick newborn care. So thank you, Joy, for the question. This is what I'll say for now. Thank you. Over.
Thank you so much, Dr. Olfonke, and you have a big job to do on the African continent, but definitely our leadership and that of the politician and other people, partners on the continent, is important. And what you said that we need more investment into this space, I think is important and quite urgent. And one of the things that you alluded to is, of course, the support, but also the space to be able to do KMC that is needed. As people might note, KMC is no longer in a corner. KMC is actually within the NICU with access to everything. So we must change the way we design neonatal care units, and it requires quite an investment. Our government is committed. So I'm actually going to be asking this question to Dr. Richard Mugahi. Dr. Richard Mugahi is the acting commissioner for child health in Uganda and reproductive health, but actually is also the assistant commissioner in charge of this. So he's holding all the positions with him. And this study has been done in his country, and he was part of the people who were providing sort of supervision and guidance to this study from a policy perspective. So Richard, with Uganda being committed to achieving SDG 3.2 for neonatal survival, what are your plans to secure more investment for neonatal care across Uganda? Richard.
Thank you. Thank you so much, Peter. I also want to appreciate the organizers for this very
I'm sure he's coming back. Internet in Uganda. Okay, Richard, we've lost you a little bit. I hope you can be able to come back, Richard.
Yes, I'm back. I want to thank you, and my apologies for the internet. I sit at the policy level, but I also have a background as a service provider. And the challenge of neonatal mortality and morbidity has really been very big. And for the last 2 decades, we've not even had a change in terms of neonatal mortality. We've just seen a slight change in the last DHS, Demographic Health Survey, in terms of neonatal mortality. We continue to lose so many neonates as a country, especially in the early neonatal period, the first 7 days. And we know the causes, we know the issues around hypothermia. We know how important immediate kangaroo mother care is. And this is what we've really focused on now as a country. We agree with all the other speakers that this is going to take an investment, and Uganda is currently finalizing an investment case specifically for newborn care, and I'm very sure Kangaroo Mother Care is going to be very central to this. We did not have adequate infrastructure, and we are now trying to make sure that there is improvement in infrastructure to deliver the bundles or the care bundles or the package including the Kangaroo Mother Care point. To be very exact, a country like ours with 45 million people, having probably only 4 standard NICUs and a few other level 2 health facilities is inadequate access, and mothers have to travel long distances to ensure that they can get the very basic minimum. And I agree with you, Peter, that only 20% of our neonates are able to receive optimal care. And this brings in an issue of access, but also our focus is going to be on the quality of newborn care. We intend to do this by strengthening capacity of our service providers to be able to deliver these bundles and packages of care to the newborn. And all these we are talking about need investment. And as a country, we've not only handled this as a sector concern, but we've flagged it off as a concern, a national concern. And we are having advanced discussions with the National Planning Authority. National Planning Authority is responsible for picking national priorities that should be focused on in the National Development Plan. So we think that this collaborative approach with the National Planning Authority will be a unique opportunity for us as a country to bring together other key stakeholders to support the plight of these voiceless souls that are being lost. The numbers are really big. It's the #1 newborn mortality is the #1 cause of mortality as per age stratification in the country. And it's now really something that we are focused on. We know the packages. There is evidence that of what works, and the OMWaNA trial cannot come at a better time than this, when we all know that immediate KMC actually saves lives. We know what the newborns are dying from, and then the immediate postnatal period, we think we can do a lot to save them, but we're also doing definitely this concurrently with the other interventions to address the major killers, like birth asphyxia, through the birth asphyxia intervention framework. As a country, we are very adaptive. We've in our plans, the plans for construction of facilities, health centers, we've created an opportunity with our engineers for providing something between Kangaroo Mother Care. It's a room, but it has also warmers and incubators, basic equipment at our community level health hospitals. Those are the first levels of CMOC. And we think that with these kinds of improvement, we will take the agenda of newborn care to a different level. Lastly, we've also considered a very strong component that has been piloted in one of our rural hospitals, and we think it's going to be very critical moving forward. And this is hospital-to-home follow-up system. This is a post-discharge follow-up, which we have ably been talking about, and the post-discharge follow-up has been piloted in one of our hospitals, and it's doing extremely well. After discharge, most of these newborns, in the bid to help them survive and thrive, they need to be followed up. And we are also putting together what it takes to have this also costed in our investment case to ensure that we follow up our newborns even at community level. I want to thank you and thank you. Our current neonatal mortality stands at 22 per 1,000, and we are committed to end in the coming 5 years to be at the SDG level of 12 per 1,000. Thank you so much. Over to you, Chair.
Thank you so much, Richard. So you have the commitment, even it's going to the National Planning Authority and government to be an agenda. And you have an investment case, but of course, time is not on our side, even for newborns in Uganda. So Richard, you have to do more. Uganda is very good at having very successful innovations, but going to scale with impact is something we need to challenge. We need to address. Professor Joy, if you could come and wind up this webinar and give some advice to the world, but also to your country. Over to you, Joy.
Yeah, thank you. And we still have time for questions. We're not winding up just yet, Peter, but I want to salute Dr. Mugahi. You know, as you have said, this is not charity to look at newborn health. This is the future of Uganda and across Africa, and the main cause of death, and also something that we can change. So we're so excited to hear the level of ambition, and also that you're not just thinking of one thing at a time. You're looking at the causes, and you want to use evidence to make the investment case. I think in the chat there has been a link sent for a similar investment case in Tanzania. And I don't know if there are any of the Tanzanian colleagues who are online, and the nearly 300 people online, but Tanzania has committed to building 100 new neonatal units, and has raised around 30 million of new funding across government platforms in the last 6 months. So it's very important. I think we heard from Sheila that when mothers die, we make a noise, and we should. When people die of HIV, we make a noise. But sometimes when babies die, I think, Richard, you said soulless voices. You know, we need to recognize that we can and we must change this, and there are ways to do this. So for the questions that have been in the Q&A, I think the team have been doing an amazing job of answering, but there is one question to Sheila. And I don't know if Sheila, if you're able to speak, if you would like to speak a little bit about your experience, and did your baby Victor have CPAP as well as KMC? Do you want to speak to that? Have we got Sheila able to speak?
Yes.
Yeah, please, Sheila, please go ahead, and thank you for your beautiful and moving story. Over to you.
Yes, thank you very much. Just like I said in the video, yes, I had a preterm as baby number 4, and really it was quite a challenging moment. Yes, I had been on the ward as a pediatrician. I had seen these babies go through KMC, but the experience of going through KMC is actually different from what you really tell the people to do. This baby is only 1 kilo, but many times it feels so heavy in the chest. I don't know, maybe because of the emotional circumstances surrounding, but I had the support from the team and I went through. I'm so grateful. Thank you.
Thank you. Thank you. And maybe we pass from the mother of baby Victor to Victor, Dr. OMWaNA. Are there comments you would like to make, especially on the way forward in Uganda?
Thank you, Professor Joy. I think as the previous speakers have talked about, in Uganda now, our direction will be to mobilize funds to make our facilities ready for this care, and should be really a whole package of care, not focusing on only KMC, but care for small and sick newborns, basically looking at the whole package, and that's the direction we are taking.
Thank you, Victor. And maybe we can, yeah.
Now
Peter,
we have some
back.
questions in some hands up. We have Franklin Banefo. His hand has been up since almost the beginning. Maybe he can be unmuted and he asks his question.
It can be quite tricky to unmute. If possible, if he could post it either in the chat or the Q&A, that would be really wonderful. And we have, I think, some more questions in the Q&A. So while we're compiling those, maybe I would like to come back to Gary. Gary, you flagged this important part on follow-up, and you didn't have so much time earlier. What do you think are the key things that the many people on this call could do now, and what are the big research questions going forward on follow-up for vulnerable newborns?
Thanks, Joy. As I mentioned in the new WHO recommendations, in looking at the evidence, that there were a couple things that we really highlighted. One is that families really need to be supported. They need to be supported all through the hospital stay, and they need to be prepared for discharge and capacitated, their self-efficacy improve, their sense of being able to manage the preterm infant when they go home. Having an abrupt discharge where suddenly you're taking care of this preterm infant can just be overwhelming for families. And so that's a really important aspect of the planning that needs to go into it, that the staff in the hospital can help to facilitate. But then there needs to be a seamless transition, into the home. And it's often difficult for families to come back into the health center for follow-up, and to then be able to provide outreach services through home visits can be extremely helpful in the care of a preterm infant. I know as a pediatrician, when I had my first child, we had a home visiting nurse that came out, and despite being, in pediatrics, it was enormously helpful to have somebody come into the home and to help with that transition that feels really pretty overwhelming, particularly when you have a preterm infant. So I think a commitment to additional home visits and equipping frontline health workers for being able to provide that support, I think, is also really, really important for making that transition. I think another aspect is, preparing the family to be supporting the mother in providing the prolonged skin-to-skin contact at home that's required. That really takes a village. It really takes the entire family coming around and serving as surrogates to provide skin-to-skin contact when the mother cannot, needs a break, needs to do something else. And so helping the family to plan for that, to really think that through and anticipate that as part of discharge planning, and then to support them when they're out in the home is something that can go a long way. And one thing we've experimented with in India is the use of a call center where people, families at home, can call in and get help through a provider that is there to answer questions and just provide support, and to send somebody to the home in case it really sounds more serious and they're unable to come into the clinic. So those are a few thoughts that I would offer.
Thank you, Gary. That's so important, and I think also really critical to underline the need to measure. So one of the reasons we don't even know where we are for scale up of Kangaroo Mother Care is that we aren't measuring in routine systems, but also the follow-up and outcomes are really important. So maybe we can pass now to Olafunke Balaji and ask you, Olafunke, has a leader for the largest group of neonatologists and those working on neonatal care across Africa. What do you think are the key things you would like to see changed in the next couple of years so more countries in Africa are able to meet the goal for neonatal survival?
Thank you, Joy. That's an amazing question. And at the executive arm of the ANA, we've been talking about being able to justify why we want more investment for newborn health in Africa. And this study has clearly shown the need for more investment as brought on the economic evaluation. So, I mean, if there's something we should be doing differently now in Africa for newborns, is really justifying why we need more money to make things better. So add on the economic evaluation to your studies, to your grant applications, and I'm sure in a couple of years, we will be able to change what it looks like for the African newborn. Thank you very much.
Thank you, Ola Funky. So we're just trying to collate some additional questions from the chat, but meanwhile, I want to pass back to my co-chair, Peter, to ask a question of our wonderful colleague, Dr. Mugahi.
Yeah, thank you so much, Joy. And many people have spoken about the need for discharge planning, but also follow-up. And I know that in Chiwoko in Uganda, with Adala Group, we have, because I'm on the board, piloted a hospital to home for newborn that are discharged from the NICU. And recently, there's been an adaptation to the public sector. And Richard, you've been at the middle of this, and you actually wrote about this in the chat. Would you tell us more about this hospital to home, if it's something you find as that it works in Uganda, in even the public sector, and how you might be able to scale up? And then advice to people who are struggling to see what to do with newborns after discharge, because we know that many of them, once discharged, either they fall sick and some of them die, and some of them have long-term complications. Richard, would you be able to comment on this?
Thank you, Peter, again for the opportunity. Of course, I did mention in my presentation that we had a very successful pilot of the hospital to home intervention, especially for prematures and the very sick newborn babies. This is very important for continuity of care in the community and transitioning. Before we came up with this, we are losing a substantial number of newborns after discharge. You've struggled so well, you've made them survive, but the care at home, these are two different settings. And our healthcare system was not able to follow them up. So in the pilot that we conducted, you can use healthcare workers, or you can use community health workers, and clearly map out what the danger signs of return to hospital for care should be. And it continuously gives the mothers or the families comfort that the health system is following them up. They are in touch with the health system. It creates a very strong communication link between the family and the health facility, for health workers for that matter. And this is very important for this child who had a challenge at birth, either premature or a birth asphyxia or any other complication of the newborn period, to be able to be followed up adequately until they are able to stand on their own and they're out of danger completely. So as the public sector, we have an opportunity that we are also piloting, or we've already piloted, but we are scaling, though not at a good pace. We are scaling the implementation of community health extension workers. Traditionally, we've had village health team members, but we are now adding in another cadre that is, we are not abolishing the village health team members, but we are adding in a cadre that is more skilled or easy to train, and incentivize it to supervise or work closely with the VHTs at community level. They are called community health extension workers. So in the community health package, we've added something on the newborn, some newborn care indicators, which these community healthcare workers should be able to continuously monitor, to continuously follow up. And we are going to create a link between the facility and the community healthcare workers so that there can be a back and forth communication about the situation or the condition of the newborns who are referred to the communities. So that's how we intend to bring it out. We're already doing that in the districts where we have choose community health extension workers, and as we continue to scale, the community health extension workers, we should be able to do this together with that. And they are able also to do psychosocial counseling. It's very true that the mothers of these sick babies actually need psychosocial support because of the mental trauma and anguish that Sheila was talking about. It's a very difficult period, and they need all kinds of support. Thank you so much. Over to you.
Thank you so much, Richard, that you have piloted a hospital at home, which is the discharge planning and follow-up for these babies. But even you want to integrate it for other children, and you're trying to scale up this in the public sector. We wait to learn from you, and if you have any guidelines, please share with the team here. But I also wanted to ask a question before I revert to Joy. I wanted to ask either Kari or Victor or Melissa, those involved, the others involved in the study, that you did this study in a very vulnerable group. Could you talk more about what type of health workers were involved in the study, and whether you find existing staff can be trained to do this, or you need a new cadre when we are going to scale up? Because many people always fear that this is a lot of work. So could you comment on this? What kind of staffing did you have, and what kind of staffing do we need going to scale? And is it existing staff? Is it a mix, or is there even a possibility for new cadres as we do more new things? Kari, Melissa, Victor, please.
Thank you, Peter. I think the point of training, you can train the new staff, but the main point is in the numbers. You need more numbers. For the current staff might not be enough to support the usual clinical work and also supporting mothers in doing KMC. So the training, adequate recruitment and training is very necessary. But the already existing staff can be trained for really to adopt the practice.
Okay, and Melissa or Kari, what is your view from what you observed in the country?
I would just add to that, Peter. I think Victor's absolutely right, but I think there's also a role for peer support. So, you know, mother-to-mother support through what is, as Sheila has really identified, it can be a really difficult time. So I think it is about healthcare providers, and we had some incredible nursing officers work who have great expertise in this area now, and I've seen Sharina is on today and in the Q&A, but I think peer-to-peer support from expert mothers is something that should really also be more closely evaluated, because certainly they have a lot to contribute.
Okay, thank you. Melissa, any comment from you?
Yeah, I agree. I mean, that was a finding that we also observed in the feasibility study at Jinja Hospital back before the start of the trial, that, you know, really support from other mothers, because knowing that the hospital workers are so overburdened, they're often short-staffed, and there's a lot of resource limitations, you know, having the advice and experience and just overall encouragement from other mothers is really important.
Thank you. And Melissa, before you go, you presented the costing data, and I know there were a lot of figures. Could you summarize it in simple terms? If we went to a new hospital in Uganda, and I know you've been to Iganga, Jinja, and the others, what would it take in terms of, can you talk like on infrastructure? What new do you observe needs to be done from this costing? And in terms of money, I know you presented figures, but I think repeating it for people always helps. Your take home in terms of the investment in order to do this, because it seems that with this KMC we need to do, we can save more, but it is not just as simple as we thought before in terms of especially the investment that's needed.
Yeah, that's a really important point. And I think, I guess the overall take-home message for the economic evaluation is that we found KMC to be more cost-effective than standard care from the provider and societal perspectives, and that it could even be cost-saving in settings where length of stay wasn't significantly shorter among babies in the control arm. In terms of the investment, I think it really varies substantially depending on the existing state of the facility. Like, for example, in the larger national referral hospital, it had been recently refurbished, so the overall costs to set up and implement were substantially lower than they were at some of the other sites. The need for floor space and the need for just basic equipment and devices that are required for to deliver reasonable quality level 2 neonatal care is key, and it's really not safe to consider implementing KMC in small and vulnerable babies until you have that basic level 2 care in place. And in terms of talking to policymakers, one of the things we're working on, and sort of guided by the team in Tanzania that already did this, is trying to develop a national investment case that for the scale up of level 2 newborn care in district level facilities. So that should hopefully be helpful, and hopefully other countries will follow that as well.
Thank you so much. So it's cost effective, but it requires some additional investment if we want to get a good return on the investment. Professor Joy, if you could follow up with any additional comments or questions.
Well, the questions are flooding in now. I just want to underline and thank Melissa for the hard work on this economic part. And just to underline, I think a way to think of this is the cost is not small for these small babies, but the return on investment is very big. So we need to recognize that we can use the data to make that case, to have more investment and get more returns. And it won't be respectful for people like Dr. Sheila and other parents doing Kangaroo Mother Care day and night in a room with no shower and no kitchen. So we have to make that case for a human rights side as well. And I really salute, the government of Uganda for moving forward on this, Tanzania for what they're doing. And I want to underline what Melissa said also, that 2/3 of the cost is human resources. So yes, we need to change the space, but if we don't have the nurses, it won't work. The Congress of International Neonatal Nurses are working with WHO, Dr. Queen Dubey and others to look at pragmatic ways to have bedside qualified neonatal nurses across Africa and to have that quickly. And this is an urgent need. We have a few really important technical questions, and I would like to ask both Kelly and Gary to talk importantly about KMC nutrition. We over-focus on the position, but there are many questions about breastfeeding, the baby-friendly hospital initiative, how we promote that. Could I ask Kelly and Gary to briefly talk about how important that is and how to do it? I don't know who wants to go first out of Gary or Kelly.
Gary, you go first. I see some very active chat in the Q&A on this with you, so go ahead, please.
Okay, I'll just comment very briefly. Yeah, I think you very rightly point out that this element of KMC is, often a little bit neglected. We put a lot of emphasis on the skin-to-skin positioning and maintaining that position, and that is extremely important. But the breastfeeding promotion is the other key element of KMC, and personally, I think that much of the impact comes through the promotion of breastfeeding. It is something that mothers need support. I mean, all mothers need support anyway, around breastfeeding and around particularly troubleshooting when problems arise. And for the preterm infant, it's particularly complicated, where you're often starting from a place of the baby not being able to suckle sufficiently well, and you've got to be providing breast milk through other means. And I think having the support for mothers during that key period of transition over to breastfeeding is really, really important. It can fall to the wayside if not properly supported, and then I think you do lose really a major source of the impact of KMC. So I think it's very rightly been emphasized. And you know, just one other point that I would like to make is that KMC really needs to fit within systems in the hospital. I mean, systems need to be modified in order to support KMC, but KMC also needs to fit within those systems. And you know, we need to ensure that it's not seen as something vertical, something that you know, it's the be all end all. It really needs to fit within essential newborn care, within small sick newborn care, you know, within the 10 elements of baby friendly hospitals, as we've been discussing within the chat. It's really part of a broader plan of care. And I think the fact that for this trial, you had to strengthen certain elements of the system before you could even launch the trial, I think illustrates, you know, the importance that this can't just be dropped in and focused on. Initially, you can't just focus on skin to skin. You also have to focus on the breastfeeding and the nutritional support, but also focus on it fitting within broader systems of newborn care. So I'll stop there.
Thank you, Gary. I mean, you know, it's easy to become siloed, isn't it, in KMC and separate KMC from breastfeeding, but they are so much part of an integrated intervention. And I think some of it's around building confidence of mothers. And I think in feeding, and Sheila talked really clearly to the difficulties in and how important it was to her as a mother to be able to feed her child. And I think, you know, we saw very nicely an increase in weight gain, daily weight gain in the Kangaroo Mother Care receiving Kangaroo Mother Care prior to stability in OMWaNA. And I think that's really powerful and maybe certainly attributing to mortality reductions that we see. So you can never be too focused on breastfeeding. But as Gary said, breastfeeding comes later. Kangaroo Mother Care is a fantastic way to initiate developmental care with your baby to promote breastfeeding, and hugely rewarding often for mothers as well. So I think it's a win-win-win, really, to make sure that we always keep breastfeeding initiatives and Kangaroo Mother Care together.
Thank you, Kelly. We just got about 5 minutes left, and there are some questions on referral networks. I'm just wondering if Ola Funky or somebody else would like to take that point. I think transferring babies in KMC is more complicated than in utero, and we're not always well set up. But Ola Funky, are there some comments you would like to make on that from ANA side or your experience?
Okay, thank you very much. If I got you right about, we're asking about referral in KMC position. Did I hear the question?
Yes, and challenges.
Yes. Okay. Well, across the space, and from my experience, neonatal transport systems are not very developed in in sub-Saharan Africa. So many times it's just a phone call, we're bringing a baby, and sometimes you don't even get that phone call. Just this morning in our newborn unit, someone called me from a few kilometers away that they wanted to send. In fact, the relatives came and said they wanted to bring a preterm from a nearby hospital, and they didn't have any idea how they were going to bring the baby. So I said, put the baby in KMC position and send the baby here. And even from this trial, we had seen so clearly that KMC reduced the rates of hypothermia significantly. So for referral in low resource settings, KMC may really be the way to go while we're working on the larger perspective, the government's investment on building the neonatal referral systems, transport systems. So this will definitely come in handy for us. And it's something that can easily be implemented at lower level, primary healthcare, secondary healthcare to tertiary centers when they do need to move babies. So that would be my comments. Thank you very much.
Thank you, Olafunke. And at this point, I think we would like to pass to Dr. Peter Waiswa to make some closing comments. And then I will make final closing comments and we will thank everybody.
Thank you so much, Joy. For us in Uganda, this has been great learning in terms of what is possible. And like I usually say in Uganda, we have a lot of innovations that show that we can actually achieve. Our main challenge is actually sustaining this in routine programs. I think we've learned a lot in terms of what it takes. And now the challenge is for Richard and the rest of us to work together to take this to scale. But also it has implications for other settings in Sub-Saharan Africa. And for the researchers, I think there are lots of questions around mental health and questions around cost, questions around follow-up, questions around improving long-term outcomes. So I think we have a tool, we have the evidence, we need to put this into implementation. Thank you, Joy, for your leadership, and over to you.
Thank you, Peter. And I just want to thank, first of all, everybody who's joined. We had nearly 300 people. I want to thank you for your questions. I want to encourage all of us to use evidence. A Lancet paper is only a Lancet paper, but in front of each of us, we have women and babies where we can change things. And I also want to echo the appreciation to Uganda, to Dr. Mugahi, to all the teams. As we take this forward together, I want to salute ANA for their leadership. And I want to encourage all of us that we can go faster together. Please do share, join. Please do join the toolkit. And please do look for resources on floor plans and data and so on. And share your resources, learn on the hospital to home pathway. And as Peter has said, each of us can change both policy and programs in front of us, but also change the research. I want to thank you all, thank the team, and thank particularly the Toolkit team for hosting this. Please do share the film afterwards, and please do take forward action with this evidence. Thank you so much.